Thank you very much for inviting me to speak on this symposium. I'm Tunde Petru, Professor of Clinical Ophthalmology from Queen's University, Belfast in the UK, and I'm going to be talking about functional and morphological methods for monitoring patients on long interval treatment. I have no relevant financial disclosures. In ophthalmology, we started with being able to examine all of our patients with an indirect or direct ophthalmoscope or a slit lamp. And sometimes we'd made very detailed drawings of the back of the eye, such as this one, as courtesy of the Wisconsin Reading Center from about 1962. As time went on, people been diagnosed with many more diseases, and the magnitude of some of the eye diseases have become a real issue. In about 2040, about 288 million people will be diagnosed with AMD, and patients with high-risk drusen, neovascular AMD, and geographic atrophy are at high risk of visual loss and will require screening, monitoring, and treatment. Treatment modalities will change over time, and so clinical pathways we have set up will need to adapt to this. When we were imaging the eye, then we needed to image the patient regularly. And this patient developed geographic atrophy, as you can see on the bottom right image. And this was after 9 years. And this patient visited the clinic, had visual acuity drops, lots of waiting time over the years. And the visual acuity, as we measured it in the clinic, hasn't changed, was perfect, 6.6 or 20/20 or 1 over the whole period of the 9 years. So we need to have better ways of monitoring these patients and make sure that we understand the visual acuity and the visual problems that they have. As time went by, we had a fluorescein angiography, which is on the left-hand corner, and then OCT, optical coherence tomography images to monitor these patients. And these were easier and quicker, but sometimes did not help us as much as we would have liked, and the patients still needed to attend our clinics. So the traditional patient journey doesn't really fit the current requirements, and it has the limitations of unnecessary referrals, long waits, crowding, multiple health personnel involved. So we need to look for solutions such as teleconsultations, virtual clinics, all-in-one app, AI triaging, e-pharmacy, and other solutions that we have been talking about for years, and COVID really helped us to move them along in every country where it was possible. So patients now can have imaging in one location, and the images are uploaded to a cloud-based server in many places, and the clinician will look at it from another place and will be able to decide if the patient needs treatment or not, and how quickly that treatment needs to be administered. This can save a journey to the patient to a central location, as this can be done in a remote location. However, a lot of these treatment pathways require a lot of quality checks, a lot of validation and training, and all the software that we had developed for these pathways required a lot of work from humans and from computer software engineers to enable remote monitoring and remote treatment options to be organized. In diabetes, it's even more complicated because multimodal imaging is key to monitoring both retinopathy and maculopathy. And patients need color fundus imaging. They might need fluorescein, which is the bottom right corner. And they also might have OCTA images, which is very similar to fluorescein, but does not require intervention. So once the patients have these imaging modalities, all of these need to be evaluated, and these take longer than evaluating just the OCT, for example, for AMD patients. However, if we do look at the artificial intelligence pathway for some of these diseases, we can see that artificial intelligence usually does very well on fluid, which is the bottom image, but it doesn't do very well with missing layers, such as in the top image. So this patient has lost a lot of vision, but seemingly has less fluid and seemingly looks better. And the reason for this is because some of the retinal layers have died away, and artificial intelligence doesn't cope very well with this, while the human eye does. So we need to make sure that when we monitor patients on longer term intervals, we make sure that they get the right healthcare professional to look at their images. So the goals of our treatment at the moment is achieving the best possible outcome with the least number of clinic visits and the least number of treatments to fend off potential side effects. And many visits that are monitoring visits, they add seemingly very little value to the treatment pathways from the patient's point of view. Say they would like to come less and they would like to have the proper outcomes regardless of the number of visits to the clinic. So in order to do this, we have, there are companies that have developed remote OCT monitoring, and this is the one example of the no-tell remote visit. And these patients who have this opportunity, they can take the images at home and they can have it analyzed using AI software, and then they can be referred to the the relevant clinic. Patients also still use some what we call the Amsler chart, and this has varying degree of success in different patients' hands and of different diseases. But however, I would like to finish off with this patient. This is a very elderly patient of ours, and he complained of further visual loss. You can see on the OCT that it really hasn't changed. And the patient then came in, and he was really worried about the winter. He was terrified of living alone. And it was really something that the OCT guided social intervention. The human factor was undeniable. So we cannot forget that our patients, regardless of not being able to see us as often, would still like to have some contact, and they would like to have their disease explained to them. So in conclusion, we are moving towards better, as to how we might be able to provide better care without traditional clinic-based care. But we do need champions to drive the process and work with our patients and patient organizations to enable such pathways to be universally accepted. Thank you for your attention.
It is a pleasure to present at the World Ophthalmology Congress on the topic of emerging therapies of Stargardt disease. My name is Henrik Scholl. I'm the founding and scientific director of the Institute of Molecular and Clinical Ophthalmology Basel, briefly IOB, and the chairman of the Department of Ophthalmology at the University of Basel. This slide shows my financial disclosures. Stargardt disease is the most prevalent juvenile macular degeneration, and it is caused by mutations in the ABCA4 gene. Research at IOB has shown that ABCA4 is the most prevalent inherited retinal dystrophy gene, responsible for about 30% of all cases. ABCA4 has the highest number of mutations in populations of European descent, including the United States, with a cumulative carrier frequency of 2.5%. The expected genetic prevalence of Stargardt disease is as high as 1 case in 6,500 individuals. As long as sufficient target cells, namely photoreceptors, have survived, the most prominent therapy approaches include gene therapy, pharmacotherapy, and neuroprotection. And in the following slides, I will concentrate on new developments in pharmacotherapy. This slide shows the visual cycle, which is a complex process where the visual pigment 11-cis-retinal is being regenerated, and this takes place in the photoreceptors shown above and the retinal pigment epithelium shown below. As a side product of the visual cycle, bisretinoids, including A2E, accumulate at the level of the photoreceptors and eventually of the retinal pigment epithelium. In the following, I will present phase 2 clinical data that were first presented at ARVO this year. Again, we see the visual cycle, and you see the role of deuterated vitamin A that is designed to block accumulation of A2E at the level of the photoreceptors in the RPE. ALK001 is a modified vitamin A where 3 hydrogen atoms are replaced with deuterium. The compound acts as vitamin A replacement functions like natural vitamin A, except that the compound forms vitamin A dimers more slowly due to a kinetic isotope effect. Preclinical data indicates that ALK001 dimerizes 4 to 5 times more slowly than natural vitamin A, resulting in an 80% reduction in dimers, preservation of retinal anatomy, and ERG function in preclinical models. The TEASE trial was a multicenter, randomized, double-masked, placebo-controlled clinical trial in atrophic Stargardt disease. The treatment consisted of ALK001 or placebo taken as 1 pill per day for 24 months. The primary safety endpoint was long-term safety, and the primary efficacy endpoint was the growth rate of atrophic lesions, and the placebo arm was prospectively augmented with natural history cases of atrophic Stargardt patients. 7 sites in the United States participated in the TEASE-1 clinical trial, and the study chair moved in 2016 from Baltimore to Basel. The primary efficacy outcome measure was the growth rate of well-delineated atrophic lesions post 6 months of treatment. These atrophic lesions were imaged by the Spectralis fundus autofluorescence machine, confirmed by OCT when needed, and represent a clinically relevant and acceptable primary efficacy outcome by the FDA. The images underwent mass grading by 2 graders. Here are the top-line results of the TEASE-1 study. The study met its pre-specified primary endpoint of slowing the growth rate of atrophy lesions. As discussed previously, the ALK001 combines both dose levels, and the untreated control combines placebo and natural history. The growth rate of atrophic lesions was 0.19 mm per year in the ALK001 arm and 0.24 mm per year in the untreated arm, corresponding to a difference of 0.05 mm per year, or a relative 21% reduction in growth rate upon treatment with ALK001, and that was highly statistically significant. Of note, there was no difference in the growth rates of atrophy between placebo and natural history. Furthermore, when excluding all natural history cases, the results remained statistically significant. When using untransformed areas, the effect size was even 28%. This slide shows a summary of the efficacy data. To the left, as we just discussed, there was a 15 to 30% slower growth rate of the overall lesion with or without inclusion of natural history cases. When we specifically analyzed the growth rate towards the fovea, there was a 34% slower growth rate of atrophy toward the foveal center. And when we compared in a post-hoc analysis the microperimetry data to a large natural history study, namely the ProgStar study, there was an about 80% slower rate of sensitivity loss in the so-called seeing retina. Another approach, namely the compound tinlarebant, is being developed by the company Belite. This figure again shows the visual cycle, and it shows that uptake of serum retinol by the RPE is mediated by retinol binding protein type 4 or RBP4. Tinlarebant actually blocks RBP4, therefore blocking all-trans retinol entering the RPE, therefore decreasing the amount of compound available in the visual cycle, in that sense slowing down the visual cycle, and thus indirectly reduces the accumulation of bisretinoids, including A2E, in the retinal pigment epithelium. Very recently, we looked into RBP4 levels in Stargardt patients and AMD patients, and also in the age dependency of RBP4 levels in the circulation, and we have not found any difference. In other words, RBP4 in its concentration in the systemic circulation is not dependent on age and obviously not dependent on disease, including Stargardt disease and geographic atrophy secondary to AMD. In preclinical research, it was shown that tinlarebant reduces A2E formation by inhibiting RBP4. In a recent phase 1 study, it was shown that tinlarebant was safe and well tolerated, and that the compound significantly reduced RBP4 by about 90% at all doses. Ocular adverse events were mild and reversible, and those data inform the design of forthcoming phase 2 and phase 3 studies in Stargardt disease, where the study population will be Stargardt patients with confirmed pathogenic mutations in ABCA4, and the objectives will be the assessment of efficacy using fundus autofluorescence and SD-OCT imaging, and the assessment of change in RBP4 concentration. Looking into the future, for an inherited condition like Stargardt disease, gene therapy appears to be the obvious approach. However, the ABCA4 gene is so large that using standard gene replacement therapy is not going to work. For at IOB, we're developing base editing to correct the most prevalent mutation, namely the G1961E mutation in the retina. We created a model, namely an ABCA4 G1961E engineered human retinal organoid that we can use for in vitro quasi-human experiments. And using our human engineered retinal organoids, we could show successful AAV transduction of retinal organoid cones using an AAV Pro-A7 TD tomato construct. Thank you very much for your attention.
Hi, I'm Arshad Kanani. I want to thank the organizing committee for allowing me to present on coming up management options in geographic atrophy. Here are my disclosures. We know that dysregulation of the complement system has been implicated in the onset and progression of geographic atrophy. Today I'll be talking about 3 programs that are targeting the complement pathway and are in phase 2 to 3 stages. First one is NGM621. It's a potent anti-complement C3 antibody. C3 is a central component of the complement system and the first point of the conversion for all 3 initiating pathways. NGM621 potently inhibits C3, effectively blocking all downstream complement signaling. NGM621 clinical development program is rapidly advancing. We have seen the data from the phase 1 trial, which showed that NGM621 was well tolerated at all dose levels that were evaluated. There were no ocular safety signals. This program has been designated as fast track by the US FDA. The proof of concept phase 2 Catalina study is currently ongoing, and it has enrolled 320 patients across 65 sites in the US. Now let's look at the design of the Catalina study. Patients with GA were randomized to 2:1 to 2:1 to either NGM621 Q4 weeks or sham Q4 weeks, or NGM621 Q8 weeks or sham Q8 weeks. The final visit is at week 56 and the primary endpoint is at week 52, and the objective is to evaluate the rate of change in GA lesion area and safety of NGM621 intravitreal injections, either administered every 4 weeks or 8 weeks, compared to sham in patients with GA. We expect the top-line results from this trial in fourth quarter of this year. The next molecule I want to talk about is evacencaptad pegol. This molecule is designed to be a specific inhibitor of complement C5. This is a pegylated RNA aptamer. We have seen the data from GATHER1 study, and we expect the data from GATHER2 study in the near future. I'll be sharing the data from GATHER1 and the design for GATHER2. In the GATHER1 trial, patients received monthly intravitreal injections of evacencaptad pegol and or sham for 18 months. The study had 2 parts with 3 different doses, 1 milligram, 2 milligram, or 4 milligram. Here are the key inclusion and exclusion criteria for GATHER1 trial. The important thing to emphasize here is that this trial included patients with non-center point involving GA, as long as GA in part was within 15 microns from the foveal center. GATHER1 study met the primary endpoint. Here you can see that patients treated with avacincaptad pegol had significant reduction in the mean GA growth rate over 12 months compared with sham. You can see the curves separate early and that separation continues till the primary endpoint. Looking at the 18 months data, we can see that there is continuous treatment effect and separation from sham that's observed over 18 months. Here are the ocular TEAEs in GATHER1 study. You can see most of these are related to the injection procedure. There were no cases of intraocular inflammation or endophthalmitis in the GATHER1 trial. Here are the CNV conversion rates that were seen in the GATHER1 study. We can see that CNV conversion rates were increased with avacincaptad pegol over 12 and 18 months compared to sham, and this included any type of CNV, and you can see that the 4 milligram dose has a higher rate compared to 2 milligrams. The data from the GATHER1 study led to the design of the pivotal phase 3 GATHER2 trial, where patients are randomized to receive either monthly avacincaptad pegol 2 milligram for the first 12 months or sham. The primary endpoint is at month 12, and it is mean rate of growth slope estimated based on GA area measured by FAF. In the second year, patients treated with avacincaptad pegol will be re-randomized to receive treatment either monthly or every other month, and the sham patients will continue to receive sham for 2 years. This trial is fully recruited, and we expect data from this trial in the near future. Last molecule I want to talk about is pegcetacoplan. This program has actually finished phase 3 clinical trials, and I'll be sharing that data with you today. Pegcetacoplan is a 44 kilodalton pegylated, highly selective bicyclic peptide that's conjugated to a PEG polymer, and it blocks C3. As a reminder, here's the phase 2 Philly study data where we saw pegcetacoplan resulted in significant reduction in the growth of GA versus sham over 12 months, meeting the primary endpoint. This led to the design of the phase 3 Derby and Oak studies. In Derby and Oak study, patients with GA were treated with either monthly pegcetacoplan or every other month with 15 milligrams. This was compared to sham monthly or every other month. Primary endpoint was at month 12, which was change in total area of GA lesions based on fundus autofluorescence. The study end is at 24 months, and patients from this study are being rolled over in the extension GALE study. Here are the efficacy results from the primary endpoint. Pegcetacoplan monthly and every other month met the primary endpoint in Oaks, but not Derby. Looking at the 18 months data, we see that pegcetacoplan reduced GA lesion growth versus sham in Oaks and Derby at month 18. The phase 3 trials included all-comer population, including central and non-central geographic atrophy. Here we can see that pegcetacoplan reduced lesion growth in patients with extrafoveal lesions in a pre-specified analysis at month 12. Here are overall TAEs across all treatment groups in both Derby and Oak studies at 18 months. Looking at serious ocular events, you can see there were 5 cases of endophthalmitis in the Oak study compared to 0 in Derby, and these cases included both infectious and non-infectious endophthalmitis. Looking at events of exudative AMD, you can see that patients treated with monthly pegcetacoplan had a higher rate of 9.5% compared to every other month, which was 6.2% compared to sham at 2.9%. Looking at intraocular inflammation, there were 21 events of intraocular inflammation that were observed in 18 patients over 18 months. There were no cases of retinitis or vasculitis that were reported associated with intraocular inflammation. So this data from phase 3 Derby and Oaks study, as well as the phase 2 Philly study, has been submitted to the US FDA, and we expect a decision on approval later this year. I want to thank you for your attention.